So now let's move on to what I think is the most high yield portion of this lecture, especially of the conditions. It's this pathway of GERD, Barrett's esophagus, and adenocarcinoma. So GERD, the pathogenesis involves a transient decreases in LES tone. And what that does is it allows acid to get into your esophagus. So it's kind of like the opposite problem we were having in achalasia, where nothing can get through. This one, you have a little bit too much of a decrease in your tone to where acid can get back up into the esophagus. So what that looks like is that normally we have a lot of acid sitting in our stomach, and that acid can try to come back up here. But if we have our lower esophageal sphincter here, when it tries to get into the esophagus, it's going to get denied. But these transient decreases in tone allows the acid to get up there. So there's several risk factors for GERD. One of them is being obese or having a high fat diet. First off, that can make it to where you have more acid in your system in the first place. But I think the more pertinent physiologic factor with obesity is that you have a lot of excess adipose tissue that can push up and put more pressure on that lower esophageal sphincter to open, and also put more force into the acid onto the LES in the first place. Alcohol, tobacco, and caffeine are also risk factors because they can increase your acid production. Scleroderma is a risk factor for the reason we just talked about, because it has, remember, decreased LES tone in the first place, and our mnemonic for that was scleroderma. And then a hiatal hernia can also be a risk factor. The reason why is because if we look at our lower esophageal sphincter right here, it's in a pretty good place because it has the diaphragm support in a way to where it can't really budge. The problem is when a hiatal hernia, what happens is that a portion of that your stomach gets pushed above the diaphragm. So this portion here kind of goes above the diaphragm. And if your lower esophageal sphincter is already above the diaphragm, it's a lot less stable. It's a lot less strong. It doesn't have the support of the diaphragm anymore to keep it closed either. And so that can already cause lower esophageal sphincter tone, decreased LES tone and more GERD symptoms. So how does GERD present? GERD usually presents as heartburn or chest pain that worsens after meals and at night. And the reason it's at night is because if you lay flat, it's easier for the acid to overcome. There's no gravitational force now limiting the acid from trying to get into your esophagus. They really like this. They like to give you a patient who recently developed asthma as an adult or has this cough as an adult. That's atypical for asthma. So just think about GERD in that presentation. You can also get hoarseness because you're having reflux into your larynx. You can get damaged tooth enamel, and you can get trouble swallowing as well. And on histology, you're going to see some eosinophils, but you're not going to see too many. And I'll talk about that. The reason why I mentioned the some eosinophils is because there's another condition later called eosinophilic esophagitis, where you get a ton of eosinophils. So if you see a few eosinophils, it still may be GERD. Another thing I want you to think about is that all of these symptoms like hoarseness, dysphagia, there's pain involved. It's important to think about whether it's GERD, Barrett's esophagus, or adenocarcinoma. And it's tough to tell the difference from that presentation. And the algorithm can be kind of confusing. So I break it down into a very easy way to realize how to triage GERD, especially on a test. So the first thing I want you to do, and anybody who you think may have GERD, you need to evaluate them for alarm symptoms, okay? And what these are, anybody age greater than 50, that's an alarm symptom. If they've had recent weight loss, if they have anemia, hematemesis, dysphagia, or odynophagia, so trouble swallowing or pain while swallowing. All of these, if they have alarm symptoms, they need to get an upper endoscopy first. Okay, you can't just treat them empirically. Those are all risk factors. Any one of those is a risk factor for esophageal cancer, and you don't want to miss that. You can't just treat esophageal cancer with a PPI, right? So if they have alarm symptoms, you should start with the upper endoscopy. If they don't have any of those alarm symptoms, if it sounds like a classic case of GERD, just some chest pain or heartburn that gets worse after meals or at night, and they're in their 30s, then you can start them empirically with a PPI or a H2 blocker. This is from our stomach lecture. I'm going to talk about the mechanism by which our parietal cells can make hydrochloric acid in our stomach. I just want to point out that our PPI and our H2 blocker, the PPI will block. So this whole pathway, just so we know, all it does is, well, one of the things it does is it just produces acid into our stomach lumen. Okay, so that's bad if you have GERD. So how do we stop that? PPIs can stop that by inhibiting this enzyme, and H2 blockers can stop it by inhibiting this enzyme. There's several complications of GERD that you need to know. First off, esophagitis, and this should make sense because the esophagus is going to be inflamed by all that acid. You can also get esophageal strictures, Barrett's esophagus, and esophageal adenocarcinoma. So let's talk about esophagitis real quick. You can have the acid in your stomach coming up, and all that acid in your esophagus will cause inflammation, and that's actually the most common cause of esophagitis. For esophageal stricture, which we talked about in the upper esophageal conditions, you can see here that if you have inflammation, you can get fibrosis eventually, and that can cause luminal narrowing. And acid reflux is our most common cause of esophageal stricture, which makes sense because they're both related to esophagitis in the first place. Now, the important one to think about is whether or not this person has Barrett's esophagus. And so before I talk about what Barrett's esophagus is specifically, we need to know what metaplasia means. So metaplasia is a reprogramming of stem cells to replace one tissue type with another. And usually this happens because of repeated cell damage. So if we're going to look at the pathogenesis of Barrett's esophagus, it is a metaplasia of our lower esophagus from our non-keratinized stratified squamous epithelium to non-ciliated columnar epithelium with goblet cells. So remember from earlier in this lecture, we talked about how most of the upper esophagus and parts of the lower esophagus are composed of this stratified squamous epithelium. So what happens in Barrett's is that stratified squamous epithelia turns into the simple columnar epithelia, and that's a form of metaplasia. So you can see here the squamous cell, all these are stratified squamous, and we end up with our simple columnar. Now, I just talked about how this is usually due to repeated cell damage. And so in this case, it's because of the repeated damage from all that gastric acid that's hitting it. And so here's another picture of Barrett's esophagus. You have your stratified squamous on the left, and then you have your simple columnar on the right. And here you can see these goblet cells here can protect us from acid. So basically what's happening is that our lower esophagus is getting damaged repeatedly by this gastric acid. And this stratified squamous epithelia at some point just says, you know, I can't do this. Like, I need help. And so the simple columnar epithelia says, hey, I got you. And they switch. And so the simple columnar epithelia starts to be produced in your lower esophagus to protect from that acid using these goblet cells. And that's all fine and dandy. The problem with that is that if you undergo a process like metaplasia, you increase your risk of cancer because you've already transitioned your stem cells, and these can actually progress to a form of dysplasia and finally cancer. So here's a picture of Barrett's esophagus. You can see a lot of the stratified squamous epithelia here, but there's a big invasion of our simple columnar or pseudostratified simple columnar epithelium that's already formed, and that's because of the damage coming in from the stomach here, damaging the lower end of the esophagus. And just don't forget this pathway. Anytime you see metaplasia, like a reprogramming of our stem cells, that's a huge risk factor, and that can form dysplasia, and finally that can lead to cancer. So now let's talk about esophageal adenocarcinoma, and we'll contrast it. While we do this, we'll contrast it with the squamous cell carcinoma that we talked about in the upper esophagus. So this is a cancer of our glandular epithelia. From our GI intro series, I mentioned that there's several glands throughout our lamina propria. I just want you to know that your embryonic GI tract in general is full of glands. So that's why you're going to see a lot of adenocarcinoma coming up, whether we talk about the esophagus here, or the stomach, or the colon, or the pancreas. All of those generally form adenocarcinoma because that's a type of glandular epithelia instead of squamous cell carcinoma. So now this is the most common esophageal cancer in the US, but the second most common cancer worldwide, second to squamous cell carcinoma. And it's usually located in the lower one third of the esophagus, which should make sense because that's where all this metaplasia is happening because of repeated insults by gastric acid. So let's look at the causes. We know chronic GERD is a big cause, and that's going to form Barrett's esophagus. You can also get esophageal adenocarcinoma from smoking, obesity, and achalasia, because remember that irritation from achalasia doesn't just happen in proximal esophagus, it's obviously going to affect the distal esophagus too. So this presents like most cancers do with weight loss. You get that progressive dysphagia that we talked about with squamous cell carcinoma because the tumor is starting to grow bigger and bigger and obstructing more and more of the lumen. Again, you get odynophagia because it can invade nerves, and hoarseness for the same reason. And on histology, you're going to get angry glandular tissue. And so what do I mean by that? On the left, these are normal glands, okay? They're doing their thing. They're very well organized. They're very circular. There's only one layer between them. There's not really dark nuclei composing any of these cells. But if you look over here, you can see how thick the tissue is and how dark it is. Whenever you see this very dark nuclei, I want you to at least consider the possibility that you're looking at a cancer. And they'll make it obvious on tests. They don't expect you to be pathologist, but they do want you to know the difference here between a completely normal intestinal gland versus adenocarcinoma. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.